Lung ultrasound may seem confusing, but we can break down the important signals into 4 distinct patterns: A lines, B lines, consolidations, and fluid around the lung. In this video, we'll look at those 4 basic patterns and their clinical relevance. I'm Dr. Alex Estelle, and this is Sonocare. Let's start with A lines. The naming scheme for lung artifacts is admittedly not the best. If it helps you remember, think A is for air. Air does not propagate ultrasound waves. So a well-aerated lung will scatter all of our ultrasound waves at the pleural line, leaving everything beyond invisible to us. Thus, when the lung is normal, we get an A-line pattern that looks like this. Here we see the pleural line sliding with each breath, and then we see beyond that a series of equally spaced horizontal lines. Only the pleural line is a real structure, and each subsequent horizontal line is the probe's attempt at making sense of the reflected waves. The ultrasound waves are bouncing back and forth within the patient's chest wall between the pleura and the probe. As the waves lose energy with each reflection and the probe interprets weaker signals as having come from farther away, we get the generation of sequential A-lines. Since the artifact is generated by ultrasound waves bouncing between the probe and the pleura, the gaps between the lines are all exactly the same as the distance from the probe to the pleural line. So when we see A-lines, we aren't actually seeing anything within the lung. We're seeing an artifact that tells us that there's air beyond the pleura. While an A-line pattern is what we see in the setting of normal lungs, we also get an A-line pattern in the setting of pneumothorax, as again there's only air beyond the visceral pleura. The key difference here is the presence of lung sliding. While A-lines are about air, B-lines are about fluid. When the lung is abnormal and air is replaced by fluid, whether that's from pulmonary edema or blood or inflammation or infection, the ultrasound waves are now able to penetrate into the lung tissue and reflect back to the probe. The tissue structure of wet lung is too thin for the ultrasound machine to resolve, and instead vertical B-line artifacts are generated. B-lines originate on the pleural line, move with respiration, and extend the entire field of view. The presence of B-line artifacts on lung ultrasound is much like the presence of white areas on a chest X-ray. You know something is there that shouldn't be, and it's often the distribution that suggests the underlying cause. There are other vertical artifacts, called Z-lines, which can appear similar to B-lines. They don't usually extend the entire field of view or move with the pleural line. It's unclear exactly what causes them to appear, but they're quite common and of no clinical significance. Another thing to consider is the appearance of the pleural line in the presence of B-lines. The pleura has its usual smooth and thin appearance in the setting of hydrostatic pulmonary edema, but can take on a ragged or thickened appearance in the setting of inflammation or infection. Let's run through 4 examples of how we can use B-lines in our clinical practice. If we find B-lines bilaterally, symmetrically, with a lower lobe predominance, particularly when paired with pleural effusions, we have a picture that suggests pulmonary edema. If we find unilateral B-lines, we have a suggestion of infection, though this can also reflect pulmonary hemorrhage or contusion in the right clinical setting. If we find B-lines bilaterally, diffusely, particularly when paired with a ragged pleura, we have a suggestion of ARDS, though this can also be seen in a multifocal pneumonia. If we find B-lines bilaterally at the bases, particularly when hospitalized patients who've spent a bunch of time in bed, this may reflect atelectasis, or in plain language, lung collapse. As with all things ultrasound, we're only adding data points to our patient assessments. While there are classic findings to different lung conditions, we absolutely have to integrate these findings into our patient's history, physical exam, and other investigations to come to the right diagnosis. A-lines are air artifacts, and B-lines are fluid artifacts, but our third pattern is not an artifact like the first 2. When we find a consolidation, sometimes called a hepatized lung or tissue-like sign, what we're seeing is complete deaeration of the lung to the point that we can visualize the tissue. This can really happen in one of 2 ways. Either the lung collapses down on itself, as in atelectasis, or the air is replaced with fluid and pus, as is the case of pneumonia. There are some nuances to assessing consolidations that we'll discuss in another video. An important thing to consider If you find something that looks like liver when you think you're looking at lung, is to find the diaphragm and use that to orient yourself. The last of our 4 basic patterns is the presence of pleural fluid. Where B lines were artifacts generated by fluid, pleural fluid appears as a true image. Fluid, unlike air, is an excellent mediator of sound waves, and we can pick up even small amounts of pleural fluid with ultrasound. The sensitivity of ultrasound to pick up a pleural effusion well exceeds that of a chest X-ray and nears that of a CT scan. Pleural fluid shows up as a dark area just inside the chest wall. It is usually characterized as either a simple, uncomplicated effusion or as a complex effusion where you may see fibrin strands or other material floating in the fluid. As with consolidations, it's really important to find the diaphragm to ensure that the fluid you are seeing is in fact in the chest and not in fact in the abdomen. As to what's causing the effusion, well, that's very much up to what else is going on with the patient. So there you have the 4 basic lung patterns: A lines, B lines, consolidations, and pleural fluid. Now there is some nuance to interpretation, but you've now got the tools to identify normal versus abnormal and to start to work towards identifying the cause of your patient's lung problem. As always, I hope you found this video useful. Now get out there and scan.